Okay, morning everybody. I'm going to talk for the next half hour about the HIV outbreak and how cocaine has impacted on that. I'm conscious there's lots of experts on the HIV outbreak already in the room, so if I miss anything out or if I say anything out of turn, please stick your hand up and correct me quickly. I always put this slide up because I never know who the audience is, but there's obviously a lot of people invested in here. But just to clarify what the background situation is, we have 60,000 problem drug users, as it's known, people traditionally problematic using opioids and or benzodiazepines. And about a third of those, it's probably about 15 to 20,000 of those are people who inject drugs. And we have about 25,000 people any given time on OST. Widespread availability of IP across the country, and this background is important when you think about context of infectious disease outbreaks and people who inject drugs. Now, in terms of HIV prevention, the cornerstones of HIV prevention are opiate substitution treatment and injecting equipment provision. There's a whole sea of evidence to demonstrate how effective these interventions, both in isolation but particularly in combination, are effective at reducing not just transmission of HIV but also preventing incident infection and reducing overall prevalence. So these things in Scotland have been very effective for over 30 years, since the outbreaks in Dundee and Edinburgh in the 1980s. There are other things that also help to prevent HIV in these populations, particularly testing, so regular testing of people at risk, and also treatment, so treatment as prevention, so those diagnosed, if they're regularly engaged in HIV treatment, we can suppress their viral load to a certain level that even if they do get into risky transmission behaviours, then the risk of transmission is lowered because they have less virus to kind of pass on. But there are also social and structural interventions that are being used in other countries and have been proposed for Scotland. The most obvious one at the moment, which is getting a lot of media attention, is a drug consumption room proposal for Glasgow. We'll talk a bit about that later. So if we go back a few years, it's kind of more of a kind of history lesson for some. This was the first time really we noticed something was going on, and you can see it here. You can see this kind of jump in HIV diagnosis amongst people who inject drugs, and it looks small compared to all the other risk groups, because much larger people at risk in some of the other groups, and traditionally much more associated with them, particularly men who have sex with men and heterosexuals there. But you can see this little jump here, which was out of sync with the overall trend of HIV diagnosis coming down on other at-risk populations. If we zoom in on that little bump, it was largely driven by new infections in Greater Glasgow and Clyde. And you can see this kind of almost symbolic event here in 2015, where the number of new diagnoses in people who inject drugs matched the number of new diagnoses in men who have sex with men, and that hadn't happened until 1985, 86. It hadn't happened since then, so it's been a 30-year gap in terms of that effective prevention, and then we've seen that changing, and you can see the trends in these other risk groups coming down, but something spiking there, which obviously was a fairly seismic event. If we zoom in either further into Glasgow and Clyde, this is the kind of trend in new diagnosis over time just for people who inject drugs, and you see this big spike in the 80s, and you see very effective prevention. So I mean, we know new infections in 2007. That's how well things were going back then. But things were starting to creep up prior to the onset of the outbreak, and then when the outbreak came in, we had a massive spike in 2015 when we had 45 to 50 new infections there. Now, I will caveat this graph. Don't look at this graph and think everything's under control, because this graph ends at 2018 and things look as if they've come back down, and it's easy to infer that things are under control. Things are not. We wouldn't use that terminology. In 2019, we know already there is ongoing transmission within and ongoing new infections within the population. I've not put the data on this graph because a lot of it's not published yet, but there is very much evidence of ongoing transmission in this population, so please don't think that everything is rosy and hunky-dory in the garden. The thing that was very unique about Glasgow's outbreak was the subtype, very much characterised by a subtype C infection of HIV, which was quite unusual in the UK and very unusual in people who inject drugs. So it was a very, very specific strain that has been circulating in Glasgow, particularly over the last 4 or 5 years. And the other thing that makes Glasgow quite unique in comparison to other recent HIV outbreaks is the gender dimension. There's quite a large female component within the diagnosis. which is quite unusual, and we've seen that increasing over time, particularly in 2017, where well over a third of new diagnoses were female. So that brings into account not just the injecting risk within the population, but also a kind of sexual risk as well for transmission there. Now, it's important to look at Glasgow in a global context. Glasgow is not alone in experiencing an HIV outbreak amongst people who inject drugs. There has been a number of different outbreaks identified over the last 10 to 20 years, and a lot of these outbreaks are occurring in places where they had effective prevention for a long period of time, so things have started to regress really in terms of the environments, and you can see those, probably the oldest one is back in Vancouver back in the 90s, but we've had lots of recent ones in North America, particularly in Europe. We had one in Dublin as well a few years ago as well, and there's certain characteristics which link all these outbreaks epidemiologically. And these are some of the things just to pick out in terms of when we looked at all these, we're part of a kind of global study group which brings all the information on these outbreaks together to try and identify what's happening. And I've just picked out some of these things here. Limited access to harm reduction is very prominent in a lot of these outbreaks. You could argue that's not what was the driver in Glasgow, because Glasgow is very good harm reduction infrastructure. But one of the things that really started to pop out earlier was stimulant injecting. So although not every one of these cities or countries across the world is injecting cocaine, which we're talking about today, there was a shift from traditionally kind of opiate using populations over to stimulant injecting different stimulants, whether it was cocaine, whether it was NPS, or whether it was crack. There was various. This was a kind of clear trend that we're seeing in different parts of Europe. So when we went to investigate the outbreak in Glasgow, one of the things we've got lots of in Scotland is data. We've got loads of data in Scotland. We're data rich in Scotland, so it's really helpful for us when we're trying to understand whether it's infectious disease outbreaks or other things in relation to drug use. So in terms of the outbreak, we had lots of data. We had the laboratory data from up at the virus lab at the Royal. We had the IP data from NEO. We had the clinical database from the Brownlee, the HIV clinical database. We have NESI, which is a biobehavioural surveillance study we do every 2 years with people who inject drugs, so we can look at the broader population, not just those diagnosed. And we also phylogenetic analysis, so we can look at the genetics of the strain all the way back to where it started. So really kind of cutting edge methods here that have helped us really understand what's going on. And one of the things that it's helped us understand is that there's a mixture of people who were HIV positive a few years ago but have only just been identified, and lots of people who have been recently transmitted the virus, so recent new infections. And you can see this over time. If you look at the kind of seroconversion in low avidity, that's an indicator of people who have contracted the virus perhaps in the last 6 months. And you can see consistently over time we've got a percentage of the new diagnoses are related to that group. And that has continued into 2019. In some ways that's actually accelerated over the last 6 months, the proportion of people who are recent transmissions. The other thing we can look at is the phylogenetics, which I talked about a minute ago, and that was very helpful in identifying where the origin of the outbreak comes from. It goes all the way back to 2005, what you would call an index case, so the very first infection associated with the outbreak. It wasn't imported from sub-Saharan Africa, as some people might lead you to believe. It's very much originated in Scotland and Glasgow, but it was effectively controlled for a long time. The individuals who maybe were perhaps transmitting it at that point were in very, very small networks, either singles or pairs. But it was only in 2015 that really flourished, when people became involved in much larger injecting networks typically within the city centre. And at the onset of the outbreak, there were 3 main transmission chains, which you can see here in the red triangles there. It's almost like a family tree, the way it's kind of laid out in that way. In the early investigations, John Campbell's here, done a lot of the interviews with the people who were early diagnosed in the outbreak, and things became quite clear, the kind of commonalities with the group. Most people know it was predominantly heroin injectors, but there was also a lot of mention of cocaine at that time. A kind of traditionally older male group at the onset, but a lot of these people were known to services. They weren't some hidden group that nobody had heard of. They were well known to addictions, to IP, to criminal justice services. And lots of experience of homelessness within the group, and people injecting in public places, particularly within Glasgow City Centre. So what we were able to do with that information, we were able to really quantify that. That was a lot of kind of individual information from interviews. We were able to really quantify that using data from the NESI study, which I talked about. So that what we do in the NESI study is we go to all the IEPs across Scotland and we interview people and we take their blood from them, and that gives us an idea of the diagnosed people, the undiagnosed people, and the people who don't have HIV or hepatitis C. So we can see the burden of infection across the whole population. And this is a paper we just published on this recently. And what that was able to show us was in the space of just 7 years, HIV prevalence in Greater Glasgow and Clyde had risen from less than 1% to about 5%. But in Glasgow City Centre here, which is I suppose the epicentre of the outbreak, HIV prevalence in the population in there had risen from 1% to over 10% to about 11%. So 11% prevalence of HIV is pretty shocking actually in UK terms. As I said, we've not had anything like this for well over 30 years, and in a kind of developed country this is fairly unusual for this to be happening. We were also able to substantiate some of those factors we had about what people said was their kind of traditional kind of day-to-day drug use behaviour and how that was kind of impacted on the outbreak, and we put all these into different epidemiological models. And what we found there was that cocaine injecting was the largest single driver of infection within the population that we studied. People who were HIV positive and injected cocaine, people who injected cocaine in Glasgow were 7 times more likely to be HIV positive than those who didn't inject cocaine, and that is even after accounting for all these other risk factors associated with the outbreak. So cocaine are very much an outlier there in terms of risk factors. That's not to negate all the other social and structural risk factors that are out there in terms of homelessness, poverty. So again, we need to caveat that, but cocaine is a major driver of what's going on in Glasgow at the moment. And we got lots of attention about that. I think one of the things that's characterised the outbreak is the lack of attention on it, particularly in the first couple of years. The media and others weren't really that interested in it, despite some communications that went out for the Health Board. It's only really in the last 6 to 12 months, particularly flanked by a lot of the debates around the drug consumption room and the heroin-assisted treatment service, that they've taken a lot of interest in it. And there was even subsequent interest once we published this paper, and cocaine seemed to be a bit of a hook for the media because cocaine is quite a sensational subject, it's quite celebrity savvy and all that kind of thing. And it did get them more involved, and actually what we've seen a lot over the last few months is quite a good media response to some of the things that are going on. A lot of good editorials in relation to what needs to be done, not just for the HIV outbreak, but for drug use problems in general, not just in Glasgow but in Scotland. Now the cocaine thing didn't come as a huge surprise because we identified it in the NESI study. You can see this is traditionally the drugs that people report they inject in the last 6 months when we interview them. Heroin dominates, usually 90% of the samples say they inject heroin. But we did see this jump in 2017-18 about people saying they injected cocaine, which perhaps was not that expected at the time, but since we know more about the outbreak it's become quite clear why. We see this kind of jump in NPS, which was concentrated in loathing at the time, and then almost back to zero because we know NPS injecting has almost disappeared in that area thanks to various different interventions. And interestingly, crack, there's been some discussion about crack, and you can see crack creeping up. It's quite small in that graph because of the heroin dominance, but it is creeping up and it's very concentrated in the east and the northeast, like Simon was describing.
Is that crack injecting that question?
Yep, so that question's about crack injecting, yep. This is all about injecting. We only really ask about injecting drug use, well, until now, that's for the next survey. If we zoom in on cocaine though, you can see it's concentrated in west central Scotland. The largest prevalence of cocaine, powder cocaine injecting, is in Greater Glasgow and Clyde, followed by Lanarkshire. We know what happens in other parts of the country, but it seems much more prominent in west central Scotland. If we zoom in even further, you can see the epicentre of cocaine injected is in Glasgow City Centre. The rates here are about 75%. It's about 3/4 of the people we interviewed in the city centre. About 350 people said they'd injected cocaine in the last 6 months, and in the Health Board it was about 40%. So it's a very big issue that most people in here already know about. But when you quantify it that much, to me it's quite important, because I usually use the comparison with NPS. NPS get huge amounts of attention at government level, everywhere. NPS prevalence never got anywhere near that. I think at its peak in Lothian it got to about 30%. It wasn't even in the same ballpark. But it's taken a while to shift, particularly people in higher power, to focus on this issue. I think this has been covered a lot this morning about why cocaine matters. There's a lot of things about decision making, cognitive function in relation to that, and there's a lot of evidence to suggest it does impact treatment outcomes. So people who are using cocaine and heroin, their compliance with OST and other things that are protective against either bloodborne virus or overdose, their compliance is poorer than people who don't inject cocaine because of the impact it has on their day-to-day behaviours. And that perhaps shouldn't be a surprise when we know it's been challenging in terms of how to manage these individuals. It's very much increased with bloodborne virus risk, either through injecting or through sexual transmission, because it does the opposite of what heroin does. It increases your libido and it makes you inject much more compulsively. And that's been covered in detail this morning. And then obviously the polydrug toxicity is also increasing the risk of overdose. So we shouldn't be surprised that we're not just talking about an HIV outbreak just now. If you look at cocaine and the death statistics, we've got another big line going straight up there. So it's having a broader impact beyond just bloodborne virus. It's having an impact on mortality as well. Just to acknowledge the other factors associated with the outbreak. The outbreak obviously isn't all about cocaine. There are things in relation to education and awareness that were very, very obvious at the start. There's been a lot of work done by SNEWF and other colleagues to try and promote not just awareness amongst individuals at risk, but awareness amongst people working in the field, because there was a lot of myths and old information stemming back from a long time ago, and people are hopefully slowly coming around to more updated information on that. I'm looking over that table to see if they are and getting puzzled looks. Also, the injection risk behaviours, we talked about sharing and reuse as well. The ineffective HIV care pathway is a very important one. At the very start of the outbreak, if you were diagnosed, you were typically asked to go to the Brownlee out at Garnavel to get your HIV treatment. Most people who inject drugs in the city centre, perhaps homeless, that wasn't really an option for them to head all the way out there, so there was very poor compliance early on with HIV treatment. That model's been completely flipped on its head, and it's much more community facing now, where people are getting their HIV medication either from community pharmacy or from the homeless addiction team or other kind of community facing services, and that's made a massive impact in getting the diagnosed cohort onto treatment and sustained on treatment. There was also very low levels of HIV testing, particularly within Glasgow, in comparison to the rest of the country, and there's been lots of different initiatives to get people tested more frequently. I think there's still a long way to go there, but there has been progress made. And then we'll talk a minute about limited out-of-hours harm reduction provision. So the response, I'll just talk about this briefly, because this isn't so much about cocaine, because there's not really been a huge response about cocaine, and we talked about the reasons why about that this morning. But very much focused on communication, harm reduction, treatment and care. The communication, as I said, has been very much focused on not just the general public, but the individuals and the stakeholders, and it's only, I think, over the last 6 to 12 months that it's been very much in the public eye about that. From harm reduction, there's been lots of different innovations done. I think John and others in the room have really led a lot of this work, whether it's to do with promoting testing in community pharmacy, extending the city centre IEP services, first of all in Central Station, where there was a new IEP opened in response to the outbreak, so that people were able to get IEP from very early in the morning to very late at night. But we know that Network Rail subsequently reversed their approval of that, and that IEP no longer opens. We also had the IEP opened up in the Simon Community Hub as well, in the east end of the city, where a lot of the public injecting takes place. And I don't think that has obviously changed the situation in recent months as well. So lots of really good work done, which has been compromised in the last few months. Implementation of low dead space syringes. Scotland just went ahead and did it. A lot of the other parts of the UK have done it through a kind of research paradigm. We just went and done it because we were involved in an HIV outbreak, and it made a lot of logical sense. And I think there's not been really any impact in terms of the users complaining about moving to low dead space syringes or voicing it. It seems to have been quite a smooth transition. John's nodding, I've got that right. I don't think we want to talk about heroin-assisted treatment and drug consumption rooms today, because we talk about them quite a lot, and this today is about cocaine, but those proposals are still on the table, and hopefully the heroin-assisted treatment service will open in the near future. And then I suppose the kind of elephant in the room at the bottom is treatment as prevention. PrEP is something you'll see in the media a lot just now, particularly to do with men who have sex with men. PrEP is being prescribed en masse. Scotland really leading the way on that. And the early signs are it's been very effective in re-engaging people who've not been in services for a while and reducing risk of onward transmission of HIV in that population. So there is now discussion about whether PrEP should be considered for people who inject drugs. And it's not licensed for people who inject drugs at the moment, and there's various discussions at different forums due to the sustainability of the outbreak or whether that's something that should be considered moving forward. And then just to finish off, the broader context is the risk environment. HIV is just a symptom of the risk environment we have in Glasgow and in other cities in Scotland just now. Austerity, inequality, poverty have contributed to increases in homelessness, people injecting in very unsanitary, unsterile conditions, and we've had outbreaks of anthrax, botulism, Staph aureus bacteremia, Clostridium novae going even further back. A long line of things, plus an exponential increase in drug-related deaths over time. And HIV is the latest kind of really terrible thing to happen to this kind of population. So we really need to take a step back and see how we're treating this population as kind of humans in some way, and how we can kind of reduce the risk environment. And that's where not just prescribing interventions, but more environmental interventions like drug consumption rooms and welfare reform and other things that are on the agenda for people. And then just to summarise, this is a historic event. It is the largest HIV outbreak we've had for over 30 years in the UK, and we shouldn't play that down. It is an important thing, and it continues. We're in year 5 now. A lot of infectious disease outbreaks go up and then they go down quite quickly. This is a very, very difficult outbreak to manage. It's very complex in terms of getting people tested, getting them into treatment, sustaining them in that treatment pathway. Cocaine is a key driver. But there is risk now, risk later, and we can't be complacent to think that everything's under control and we move on to the next thing. This will stay with Glasgow for a long period of time because of the sheer volume of people that are involved in it. HIV is a lifelong condition that people have to manage in relation to that, and we now have about 150 people diagnosed in that cohort. The one good thing, if there is anything a good thing to come out of it, is it seems very controlled in Glasgow. There's no evidence of spread to other neighbouring health boards in any kind of sizeable way, and that's probably credit to the prevention response that goes around the country. I think that's me.